Dawang and Becerra, dear members and guests. My name is Henk-Jan Verkade and I'm a pediatric hepatologist from the Beatrix Children's Hospital, University Medical Center, Groningen, the Netherlands. It is my pleasure to contribute to this session by my presentation titled Keeping Compensated Liver Cirrhosis Compensated. Let us start with the definitions. Cirrhosis is the final stage of progressive hepatic fibrosis, characterized by distortion of the hepatic architecture and formation of regenerative nodules. Cirrhosis can be compensated when the liver is coping with the damage and nevertheless maintaining its important functions. The reciprocal part is the decompensation. Then the liver is no longer able to perform all its functions adequately. This slide shows the different stages of fibrosis via compensated towards ultimately decompensated cirrhosis. In the early stage of fibrosis, the left yellow bar, there is not yet portal hypertension. Upon progression of fibrosis, signs and sometimes symptoms of portal hypertension appear. This stage of compensated cirrhosis, the two middle columns of this figure, can last for many years. As stated in the definition slide, this stage is characterized by histological damage to the liver and portal hypertension, but at the same time, adequate maintenance of the major hepatic functions. When one or more of the major functions of the liver start failing, the stage of the most severe form of cirrhosis is reached, decompensated liver cirrhosis. Although it is possible to temporarily address the decompensated functions of this liver in a severe stage, decompensated cirrhosis should be regarded as a life-threatening condition and, in general, requires a liver transplantation for a long-term prognosis of the patient. The topic of my talk relates to prevent patients progressing from compensated phases to the decompensated phase. This slide shows the potential gain of keeping cirrhosis compensated. As a disclaimer, this study was on adult patients, of whom only 5% was available for transplantation. Nevertheless, it clearly shows the difference of those patients who had started with a compensated cirrhosis at time 0, the red line, compared to decompensated cirrhosis, the blue line, at time 0. It also illustrates that already within the early stages of the disease, decompensated cirrhosis was clearly a fatal disease for many of them. Within about 2 years, 50% of the decompensated patients had died, whereas the percentage in the compensated cirrhosis was limited to 13%. Since the difference between compensation and decompensation is failing of major hepatic functions, I've chosen to use 4 major hepatic functions which are areas of decompensation. The following functions will be addressed: protein synthesis, bile production, blood filtering / perfusion of the liver by the portal vein, and fourthly, detoxification. The first major hepatic function involves protein synthesis. This is actually a clear area of decompensation, either chronic or acute. Of course, protein synthesis is needed for growth. I would stress that length may be more reliable than body weight in end-stage liver disease. Also, and frequently underestimated, is the effect of protein synthesis for the generation of muscle mass. The importance of sarcopenia has been highlighted recently and should be used in estimating the adequacy of the major function in protein synthesis. A simpler estimate is the mid-upper arm circumference. Another and sometimes underestimated hepatic function for which protein synthesis is essential is the adaptation to physiological challenges, such as puberty. patients with end-stage liver disease can actually delay or not at all come into puberty in the conditions of end-stage liver disease. Finally, and usually more clearly visible, is the role of protein synthesis for generating enough protein for colloid osmotic pressure. The second major hepatic function involves bile production. Bile production serves two functions. Firstly, the secretion of endogenous and exogenous compounds, including bilirubin and bile acids. Secondly, bile components are needed for the efficient absorption of dietary fat and fat-soluble vitamins. Indeed, a slow but progressive increase in total serum bilirubin concentration may be an early sign of a cirrhotic liver starting to decompensate. The third major hepatic function that can be regarded as an area of decompensation involves the hemodynamics, namely the role of the liver as a perfusion filter of the blood that has drained from the gastrointestinal system by the portal vein. Note that approximately 20% of the cardiac output enters the gastrointestinal system. Under physiological circumstances, roughly 95% of this amount is then drained via the portal vein through the liver. The liver is therefore functioning as a perfusion filter. Upon cirrhosis, however, a static and dynamic obstruction of the hepatic perfusion capacity exists, which usually increases over time. Obstruction of hepatic perfusion leads to increased portal venous pressure or portal hypertension. Consequences of portal hypertension are splenomegaly and ultimately hypersplenism, the development of varices and the risk of variceal hemorrhages, ascites, and a decreased gut wall barrier function. Upon the development of collaterals and thus of gastrointestinal blood that is bypassing the hepatic filtered perfusion, the first pass effect of the liver as a gatekeeper for intestine-derived products is compromised. The final major hepatic function, which also is an area of decompensation, involves the detoxification function of the liver. This can be clearly identified by delayed clearance of endogenous and exogenous compounds, like ammonia, drugs, cholesterol, and others. Reviewing the major hepatic functions and the areas of decompensations, it's still the question, how can we keep compensated cirrhosis compensated? And this particularly with respect to protein synthesis, bile production, the blood filtering perfusion function, and the detoxification. Before, I would like to provide you with my personal advice how to keep compensated cirrhosis compensated. I have two general remarks. First, I regard that to continue monitoring, as you may have done before, is time and again an active treatment decision and should not be a lack of decision. I have doubted if I would say this, but I do it anyway. Wait and see is a sort of negligence for the patient. Secondly, the natural history of compensated cirrhosis involves at some time point a decompensation. Therefore, adequate treatment of cirrhotic patients include the timely recognition of starting of decompensation and also therefore the timely start or referral for the next level treatment, which is frequently liver transplantation. Note that donor organs may not be readily available, and thereby the time needed to bridge to transplant may be longer than you would wish for. Herewith, I would like to give you my personal advice on how to keep compensated cirrhosis compensated. It consists of 5 items, and I suggest that you check each of the 5 at least every 6 months, maybe for young patients even more frequent. First one is look out for new developments to treat the primary cause of the liver disease or its secondary consequences. An example is the development in antifibrotic drugs. Second, buckle up. Optimize and monitor the patient's nutritional condition. Third, screen for early warning signs of decompensation. Fourth, screen for rare but severe complications of cirrhosis. And 5, assess the patient's reaching of developmental milestones and his or her ability to engage with peers. The nutritional condition in cholestatic liver disease, including cirrhotic liver disease, is quite well known. This figure comes from a recent review paper that's been in press on the causes of the malnutrition. Factors contributing are malabsorption, decreased food intake, and increased energy requirements, all leading to the malnutrition state. How to prevent or reverse the cholestatic malnutrition follows the same 3 lines. Administer increased requirements, including energy but also protein, frequently underestimated. Guarantee that the prescribed amounts actually arrive in the patient. And finally, adapt the food composition based on the impaired fat solubilization. I would like to refer to this paper, coming up later this year. But in addition to this position paper from the ESPGAM and NESPGAM combined on nutrition support of children with chronic liver diseases in JPGN in 2019. Another advice involves the screening for early warning signs of decompensation. An early warning sign of decompensation involves the temporary decompensation of one or more of the 4 major functions upon a transient challenge, for example an infection or a reaction to trauma or surgery, as indicated in the next slide. This slide is derived from sports medicine and illustrates the risk of an athlete becoming overtrained upon intense training. One could regard as a challenge, such as an infection to a compensated cirrhotic liver, as training for the liver, which has a limited reserve capacity. Upon the challenge, the performance may decline, for example, serum albumin as a liver function parameter. After the challenge has been met, for example, the infection has recovered, there is a recovery phase. Both the depth of the dip in the liver function parameter, as well as the complete or incomplete recovery, may indicate an early sign of an imminent decompensation. To bring back the scheme of earlier in my presentation, this illustrates that the discrimination between orange and red is not always directly permanent. It may be that the transfer from the orange to the red phase initially is temporarily and only challenge related. Nevertheless, if you do see that upon a challenge, as indicated in an infection or trauma or else, already gives kind of temporarily decompensation, then it should be a warning sign that the reserve capacity of the liver is limited. Early warning signs, however, may not be acute. They may be gradual but slow, like a slow increase of serum bilirubin levels. That already should warn you that perhaps the secretory function of the liver is starting to fail. Also, looking back in the past year, for example, unscheduled interventions and/or admissions should warn you of imminent decompensation. This may be GI bleeds or severe infections or else. I am aware the word GI bleeds has been around, and this also necessitates to discuss primary prophylaxis for varices. I will keep it short because, based on Cochrane reviews, we do not have any recommendation